Hello, everyone, and welcome to this special episode of CCI Cast. I'm Aaysha Cader. I'm an interventional cardiologist based in Dhaka, Bangladesh, and I'm joined by Dr. Shadia Ruiz from Detroit Medical Center, and both of us are part of CCI's social media editorial team. As part of CCI's 100th issue in commemoration, we will look at some of the impactful papers that have been published at the journal over the years. And to do so today, we have a very special guest. Dr. Samir B. Pancholy is Professor of Medicine at the 𝖁𝖓𝖓𝖐𝖊𝖓 Commonwealth School of Medicine in Pennsylvania. Welcome, Dr. Pancholy, and thank you for your time.
Thank you, Aaysha, and thank you, Shadi, for having me. This is a great honor. I'm privileged to be here.
Thank you, Dr. Pancholy, for your very impactful work over the years, and you've published prolifically, if you will, in CCI, particularly in the space of transradial intervention. And today we'd like to start off the discussion with perhaps a brief overview of the PROPHET trial, which was a landmark trial in terms of an intervention to reduce radial artery occlusion. Could you set the scene for us with what was the thought process behind you doing that trial, and a brief overview of some of the impactful results from it, please?
Yes, so it's always good to relive the lanes of history. And so, I started doing radial access for my interventional practice in 2001. And, that was a very early time. It was practically a few years after the Europeans had applied this access site to, coronary intervention. Again, everything's born out of necessity. As we all know, necessity is the mother of invention. So one of the problems we were having with the emergence of stenting is the intensity that we required of anticoagulation. In those days, for most of you, you probably would not imagine this, but we used to give warfarin to patients with stent for 4 weeks, and they also got antiplatelet treatment, etc. And during the procedure, they got very high coagulation. So the femoral complications were skyrocketing. Glycoprotein 2B3A receptors had come into vogue, and they were very favorable for coronary outcomes, but they had again ruined the femoral scene quite a bit. So that's what led to the radial access being born, and then or actually brought into the coronary space. So I started 2001. And again, like anything else, once you start applying any particular modality very broadly, you start seeing its negatives every once in a while, very frequent. In this case, it was every. So we started artery occlusion. The access site was very elegant. We hardly got any noticeable bleeding, certainly never got any major bleeding. Transfusions disappeared, but we were seeing loss of radial pulse and future access. In those days, we were seeing it almost 10 to 15% of the time. So that piqued my interest. And I was very much into outcomes research from my training. So I was creating a database of my patients who undergo any procedure. And as a part of that, we had some interesting observations. First, we knew that we were closing a lot of radial arteries, and we were obviously looking for a solution. But interestingly, we also observed that people who were complaining of the tightness of the radial band on the wrist, they were somehow not occluding their radial artery. All those patients who were the complainers had a surprisingly high rate of radial patency, or a very low rate of radial artery occlusion. And then we found out that what was happening was the nurses were going and loosening the band at that time. Now, mind you, we did not have the fancy balloon inflation type TR bands, etc. We had a very simple zip tie like hemoband that the dialysis folks used to use. So the nurses were just going and unclicking the hemoband a few notches to make the patient comfortable. And in doing that, what they were achieving was patency of the radial lumen while they were compressing. They didn't know that. We didn't know that. But analyzing our database, we found that the complainers were not occluding as much. And quickly, we deciphered the mechanism of it. And obviously, it was an observational speculation at that point. And that's what led to the design of the PROPHET trial, which is to loosen the hemoband to a point where we still have hemostasis, but we have flow in the radial artery while we are compressing. So that's where it all started.
Wow, that's fascinating and so interesting that an astute observation is what led to the design of this RCT, which yielded very impactful results. But when you said about the hemoband, that also actually piqued my interest, because in most parts of the world, in low-income countries, and it's in fact South Asia where I come from, the uptake of the radial band is also rather limited. Sometimes compression with a dynoplast, an elastic band that is still the method of hemostasis. Can patent hemostasis be applied across the board to all patients?
Yes, so that's a very important point that you're making, is that patent hemostasis is a process more than a device. And so any device can be designed or made to deliver patent hemostasis. In fact, you don't even need a device. You can practice patent hemostasis by manual compression. It is basically a simple concept of not applying excessive pressure at the access site where you lose the patency or the flow in the lumen. So if you are manually compressing, that easily can be done with your fingers. And if you're using an elastoplast, you can do that with that. Or you can even use one of these simple bands like hemobands. And then obviously the more titrable the device, the easier it is to practice patent hemostasis. So yes, you can use it across the board.
I think that's a very, very important point to make, that there are no limitations to the practice that would eventually reduce radial artery occlusion. So if we chat a bit then about the sequel to this, which was PROPHET 2, and where you also then looked at ipsilateral ulnar artery compression in order plus patent hemostasis versus patent hemostasis alone. If we could talk a bit about the endpoint. So in PROPHET, you had an endpoint, you looked at radial artery occlusion at 24 hours and 30 days. In PROPHET 2, you only looked at it at 30 days. So in the RAO space, what should be the ideal endpoint we'd be looking at in terms of trials?
Yeah, so I think, in both PROPHET trials, we looked at the 24-hour and the 30-day endpoint, but our sample size for PROPHET 2 was powered to the 30-day endpoint because that was expected to be the less frequent endpoint. So we wanted a more robust trial mathematically that does not lead to any confounding type of a result because of sample size and power issues. And so we designed the trial to be powered, so to say, for the 30-day endpoint, but obviously it was amply powered for the 24-hour endpoint, which we did record 24-hour endpoint and we published it, as etc. So both trials had a very similar endpoint design. The only thing we learned from PROPHET was that the 30-day endpoint is significantly less frequent, and so when you design the next trial, you should probably go for the 30-day endpoint as a conservative sample size estimation tool. I think that 30-day endpoint is probably a more robust endpoint. Having said that, if you use the best practices and your RAO rates are very low, especially in a randomized setting, then the sample sizes become very unmanageably big. And then if you don't follow those rules and you do a trial with small sample sizes, you're very exposed to mathematical limitations.
That's such a crucial point, particularly because, I mean, given current best practice, which is not just patent hemostasis, but many other aspects, radial artery occlusion has effectively reduced to less than 1% in most RCT settings. So even I was thinking in any upcoming trial, how would you manage sample size numbers? Because presumably you would have to maintain best practice to test an intervention on top of it. So like you said, the numbers would be insane.
Absolutely. So I think, there are two aspects to it. The randomized control trials, and actually that's a very interesting observation that you just alluded to. In the RCTs, the radial artery occlusion rates are very, very low nowadays. And that is basically because of the Hawthorne type of an effect. So when you turn the lights on, when you're doing the study to particularly study radial artery occlusion, you are going to pay so much attention to all the best practices that you will achieve a very low rate of radial artery occlusion, as you're seeing in many contemporary trials. Whereas if you look at the real world data sets from the same time period, you see much higher radial artery occlusion rates. In 2021 and 22, if you look at the publications for radial artery occlusions, the RAO rates in the RCTs is close to, like you said, 1% or sometimes even less. But if you look at the same time frame, similar centers, very high quality centers, publishing observational research where the randomization and all the staff was not there, you would essentially see tenfold higher rates. There are RAO rates of 9 to 15% in high quality research that is published even last year. So I think, there is a large element of Hawthorne effect. When you're doing a randomized controlled trial, we have to be careful interpreting the burden of radial artery occlusion in the real world, because that may not reflect the real world.
That's a very, very pertinent point. So to add to that, how can we improve best practice to prevent radial artery occlusion, particularly in busy cath labs around the world, where the procedure gets far more precedence than the prevention post-procedure?
Absolutely. And I think, one of the things that is a limitation of patent hemostasis. So, I have observed that one of the most dominant factors predicting whether you will close the radial artery or not is actually hemostasis. During the procedure, when you introduce the hardware, you're basically causing injury. But when you compress the artery for hemostasis, then you're converting that injured lumen into either a thrombotic occluded lumen or a lumen that is on its way to healing with patency. And that is completely driven by hemostasis, especially after you pull the sheath out. So what can you do? Well, patent hemostasis is a very robust concept. It works. The only problem is, in order for it to work, the team monitoring hemostasis needs to be very, very astute. They need to be trained, they need to know what they're doing, and most importantly, they need to invest their time in making sure that the radial artery is not collapsing because of changes in the hemodynamics that go on when the patient falls asleep or when the blood pressure comes down, etc. So even though it's been 14 years this year since the publication of the Prophet trial and the term patent hemostasis being out there, the adoption of patent hemostasis outside of randomized controlled trials is very low. So I think, what we thought 6 years ago, or maybe 8 years ago, is that there needs to be something that delivers patent hemostasis without the team paying so much attention to the detail. Can we devise something that can make the artery remain patent afterwards while you are compressing? And that's where this whole idea of ipsilateral ulnar compression came in. It was just exploitation of local hemodynamics and physiology, which allows you to increase the flow in the radial artery by compressing the ulnar artery. And it's a very simple hemodynamic equation. The hand and the palmar resistance in the vasculature is drastically reduced when you compress the ipsilateral ulnar artery. Because the resistance goes down, the only open channel, the radial artery, will be recruited to deliver much higher flow. And when you get higher flow in the radial artery, flow is inversely related to thrombosis probability. And that's what reduces the radial artery occlusion. So that's been now shown several times in randomized settings and even observational settings, et cetera. So I think, going forward, I think that's where the value is going to be, is to use devices and techniques that deliver patent hemostasis without so much investment from the team.
Dr. Pancholy, one question about the patency as well. what kind of cocktail do you routinely do for any diagnostic or PCI cases, apparently, but just to keep that patency rate higher? Some people are conservative in giving anticoagulation ahead of time till they finish the diagnostic part of the procedure and confirm that there is a PCI needed, or you recommend routine anticoagulation after insertion of the sheath.
Yeah, so I think, very good question, Chari. And I think, anticoagulation is an absolute must, even for a diagnostic only procedure. Uh, the, 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 the time when the anticoagulation actually delivers its effect is actually after you pull the sheath. So while you have the sheath in the artery, one of the benefits of anticoagulation is that you don't get local thrombosis around the sheath and more proximal to the sheath on your catheters, etc., which is very important. But once you remove the sheath and you apply pressure, even manual pressure, you will start to thrombose the lumen very quickly if you don't have any anticoagulation. So every procedure, when you puncture the radial artery, you should administer adequate anticoagulation, not just any anticoagulation, but adequate. And from what we have learned from the literature, the most supported dose of heparin, and heparin happens to be the best anticoagulant, at least based on the evidence. The most literature supported dose of heparin is 5,000 units given as a bolus. Now, if you deal with a population like a lot of us do, very obese or very lean in some parts of the world, you can adjust your dose to 50 units per kilogram for diagnostic procedures. Luckily for PCI, we use much higher dose anyway. And so the radial artery, automatically gets protected when we do PCI from an anticoagulation standpoint. But yeah, anticoagulation is an absolute must do best practice.
That's brilliant. Thank you for this very insightful trip down memory lane leading up to contemporary practice. But perhaps we could conclude with asking you, what do you see as the future in terms of reducing RAO, and also in terms of maybe what the next big trial should be?
So very good question. I think the future of PCI in general is, going down the complex lane. We are going to do a lot of complex PCI, or what we call complex right now. It might become bread and butter in 10 years. And with that, what we are requiring is a little bit bigger size than what we've been used to use from the radial access. Now, the slender movement and a lot of us have become very comfortable doing mostly any PCI using 5 and 6 French introducers and catheters. But at the end of the day, if we were to be given a pentothal type of an interview, we would all admit that it is much better to have a 7 French guide when you're doing a left vein or when you're doing a CTO. For CTO, there is even data that larger guide is better. So I think the future is going to be larger bore radial PCI with compression, with compression that allows you to maintain radial artery patency even when you use a larger bore catheter. So our sheaths have become more friendly. We have the slender sheaths available with every brand now. And our hemostasis with newer devices and with ulnar compression, etc., there's already emerging data that with 7 French, you get 1% occlusion rates when you compress the ulnar artery simultaneously. And so I think, that's where the future is. More complex PCI, the flexibility of using larger bore from the radial access, delivering the benefits of radial artery as far as no bleeding and comfort and cost benefit, and less burden of radial artery occlusion than what we are dealing right now with 7 French, hopefully equivalent to 6 French and 5 French introducers.
Fabulous. Thank you very much for this very insightful discussion, and also for your impactful work in this space over the years. Thank you.
Thank you. I thank CCI for being a supporter of my work from the beginning. I would particularly like to extend my gratitude to Dr. Chris White and Steve Bailey, and all the way from Dr. Hildner onwards. and the team. I am a big fan of CCI, and that is my home. Thank you.
Thank you so much, Dr. Pancholy. Pleasure being with you today.